So what I'm going to do is tell you a little bit about the story of how GHRF developed, because I think it's instructive for a couple of reasons. One is to give you a sense of how different cultures are even here in the US, and the cultures I'm talking about are the culture of medicine and the culture of business and the culture of Silicon Valley. So I'm Erica Weirich. I'm a physician at Palo Alto Medical in family medicine, and I teach at Stanford in global health, and I assist Dr. Mai Lee, who's here, in serving her projects, her health-related projects for the Engineering for Good course, which has been just amazing. But we started GHRF in 2007, and really it started from sort of a sense of shock that came out of discovering that all of the projects that several of us had supported in international health over time had collapsed. And as an example, I had worked in the far north of Pakistan, where now the Taliban are, in the very northwest frontier provinces in the Karakoram Mountains. I had worked there for about a year in maternal and child health in a very well-designed program that had been created by the Aga Khan Health Service there in Pakistan, a Pakistani-designed program. And I wouldn't have imagined that program would ever have gone away, because it was designed in coordination with the Rural Support Program and really carefully created to develop so that there would be education developed and that the villages would be empowered to provide their own health service down the line. And I worked in a national health service in England in a refugee health program, and in former Soviet Georgia in a reproductive health program, all very well designed, interesting programs. And then went into training and got a master's in international development policy, and thought I was kind of situated to deal with what I thought the problem was with sustainability in health development, which I thought was that most international health interventions were sort of top down at that time. They were really dropped on a community. So some of what Dr. Vasu was describing, you see very, very much in health. As an example, in the far north of Pakistan, the World Health Organization, about 10 years before I worked there, had put in dry latrines or toilets in all of the villages to try to deal with the #1 cause of mortality, which was diarrhea. Diarrheal disease was the biggest killer. Only they hadn't really looked at what the issues were in the community with using the water source to go to the bathroom. Like, why was that happening? And what did the people think about using a dry latrine? They just built the latrines, which was millions and millions of dollars to haul in the materials up across the Karakoram Highway, which is a very frightening thing to drive on. Anyway, they were basically unused, and the only thing the WHO knew was that the diarrheal disease death rate had not dropped. Nothing else was really looked at as to what the problem was. And by the time I got there, almost invariably, I'd go into a new village. I was doing traditional birth attendant and health worker trainings, and I'd go into a village and someone would say, "Oh, we have one of your bathrooms." And they would take me over to this building that hadn't been touched since it was built, covered in vines and ivy, and creak it open. Like, my one big phobia is spiders, filled with spiders, invariably filled with spiders. And I was just like, that's okay, let's all go down to the river. And it turned out that it's sort of considered barbaric to imagine going to the bathroom without a source to wash yourself in that area. That was the problem. And if you don't have germ theory, or you don't understand fecal-oral transmission, because the education isn't at that level, then you're not going to be able to solve that problem yourselves as a village. And it chopped down and dropped in, they thought it was really disgusting to have one place where you could really imagine, one place closed in where everything was going to be sitting. I mean, just disgusting. Really, you could see it from their perspective, just by asking. So I thought that the main issue was one of appropriate technology and appropriate interventions. Millions of dollars were being spent by very well-meaning organizations, WHO, USAID, trying to fix problems in the developing world in low-resource areas. And really, there was almost no outcomes data being collected. But it turned out that after I'd gone through training and my master's degree and everything, I was all excited in my first sabbatical to go back to one of the programs I'd served, and it turned out they had all collapsed. And this isn't an issue of just appropriate technology. This was something else, and I didn't really know what. And by that time, you know, I'd come out to California. I was in the Silicon Valley area. I had lots of friends here, and lots of people in business and technology to discuss the problem with. And we kind of got together and said, well, I wonder if we can look at some well-working systems of health delivery and try to understand from that what's generalizable. And then of that, what can we offer to help sustain programs in health development rather than using our time as a Band-Aid for, you know, some medical problem where when we're gone, our resource is also gone from the community. So that's where we started, and that was in 2006, 2007, we started Global Health Research Foundation. And by that, at that time, it was already a group of engineers, economists, technology folks, and a few doctors. And it was sort of foreshadowing, but the physicians became less and less and less important in the organization. We're really almost nominal at this point. But what we did was we looked at a couple of well-working systems. One was Bhutan, which had self-created a health delivery system in the 1950s, and even in the last 10 years before we got there, had reduced child mortality by 25%. So huge improvements in health throughout the country. They had almost 90% coverage of vaccinations throughout the country. But there was nothing written on how they'd done it. We knew Gates had given them $1 million at one point, but there was nothing written. Nobody had gone to see, a very closed culture, very hard to get in, and at the time, very few people had gone. So we went to take a look, and we devised a knowledge, attitudes, and practice survey, you know, for health workers, villagers, health delivery people, everyone. And we did a very thorough knowledge, attitudes, and practice survey on the health delivery system. And we learned a lot about it. One of the things was that it was really developed together with the traditional medicine program, and that made it very acceptable. But there were some other things that were more generalizable. And there were things that were not generalizable, that were very interesting. Like there was basically a benevolent dictator, the king, who everyone loved. And now it's a democracy, so I went right before that happened. But that allowed the system to be put into place, and that's not very generalizable. But then there were some things about the system and how it was implemented that were very generalizable, and they were kind of counterintuitive. It was really interesting. Like we always think in medicine about taking people from an area, training them, and putting them back in, so that we're always using local people to give their own local communities to provide health. And that's been a concept since an old text called Where There Is No Doctor, is a wonderful treatise on how to provide appropriate medical assistance to communities. But there, they actually had a service in which every 7 years the health worker moved, and the health worker and the teachers, actually, as it turns out, aren't allowed to go to their home village. And the reason they did that was because they started it the other way, but they found out that people would get too caught up in their politics, in their cows and farms and things like that, to be focused on their job of teaching or health provision. That was fascinating, really interesting. And there were some other things too. And in the end, looking at the system and a few other systems, we discovered that there were two things that we thought we might be able to provide some tools in, and those were assessments and outcomes. And it's really just what Dr. Basu was talking about, where assessments, meaning like rapid knowledge, attitudes, and practice, or rapid understanding of where is the problem, where are the resources going, who else is working on the problem, what does the affected community think the problem is, what has been tried and failed, and why. And then in outcomes, where is the disease or problem now, what interventions are working, which are not, can we do disease or medication surveillance, can we target and manage resources, quality assessment and improvement and test of change. And it turns out that this was a transfer of technology from here to there. We were doing that in our medical practices. I could take a look in 5 minutes at all of my patients whose blood pressures were over 150 in my own private practice at Palo Alto Medical in an instant. I could just call up all my hypertension patients who were not controlled, or all my diabetes patients whose 6-month average blood sugar was too high. And I could call them all and find out what was going on and get them in. So we thought, these resources are here, what are they? And the technologists in our group said really what that is that's warehousing the data and then ensuring that that data is being reported out quickly enough or accessible quickly enough to then allow action. So that's where we started. So we started actually with a data warehouse. And one of our first projects was the Uganda Malaria Surveillance Project, which was a fascinating, really excellent approach that Uganda had developed to use 10 what they called sentinel site clinics, or 10 clinics evenly distributed through the country, where they were, at every clinic, every fever was tested for malaria, whereas at most clinics, people would guess, you know, this is probably malaria. The health worker said, we know if it's malaria or not, and they would give the medication. So there's lots of inappropriate providing of malaria medicine, and then there was lots of resistance to malaria medication. But at these sentinel sites, everybody with a fever was tested, everybody, and they paid everybody a little more to come to work, you know, because that was really important, because most of the time in health service, they weren't paid enough necessarily to show up all the time. They had to make some extra money. So that was all working well, but it was taking like 18 months to clean and analyze the data, because they were doing it by hand to find out, you know, where malaria was in that sentinel site system. So we basically put it together in an open platform, and this was our tech team. I learned all these words. I knew nothing about them as a physician. We put that together in an open platform, a SQL-based data warehouse, and then wrote some, you know, worked together with to find out what they needed to know in real time, and got that reported out and helped them develop dashboards, really like we were using in clinic, but all very simple and open platform. And then it turned out that that problem was solved, and they could get their data back fast, but it's still, you had to drive 6 days out to some of these sentinel site clinics, and you would lose that person, that IT person or that analyst, for those 6 days to go and get the disk, and oftentimes there were viruses on the disk, and they'd get back and you still didn't have the data. So our IT person at the time, and this is back in 2008, he basically bargained with the telephone company to turn on the phone line at the end of the month so that he could use a file transfer program, which you put on all their computers, to drag and drop the data in. And you could only do it once a month, because otherwise people tended to use that network for other web surfing and everything. So they drag and drop their data into the file sharing program, and then that was accessible in Kampala, and that saved the 6-day trip out through the Congo, which was at war at the time. You know, it saved an enormous amount of time, and that was cobbled together. I mean, imagine. As we were doing all that, we saw that everybody had cell phones, and as we went along, sort of working at sort of formalizing some of those tools so that they could be transferable to other communities and other diseases, we discovered that even in the most remote areas, people had at least feature phones, and as time went on, even smartphones. Fascinating. In one village we were in Nepal, we asked people who had a smartphone to raise their hand, and it was like half the village had a smartphone. It was fascinating. And so the realization of how much access to information and how much empowerment could come from that was really just amazing to us. So so we began to formalize these open platform tools and formalize the process of understanding what the needs were. And that was really, really where we began to serve the projects that we're serving. And now we're serving projects in Tanzania and in Guatemala, in Bhutan. We went back to Bhutan to give them the tools that we had developed, and they've also developed their own EMR type tool for their outpatient service. And really, it's been fascinating to help to provide some of the information and share the information from community to community about what's been tried and failed, and allow these tools to begin to serve the problems that people are finding themselves in health. So that's been kind of our journey.
Thank you, Erica. That was great.